many people have ever seen the imaging in real life of a pediatric stroke, not in books, but in real life? Not very many. Not very many at all. What I'm going to address is, I'm going to start by talking about the size of the problem, and then a little bit about the etiology and diagnostic definitions of arterial ischemic stroke, which is what I'm really going to talk about. And then I'm going to talk about the role of imaging, infarct patterns, and how that helps us diagnose particular diseases. The importance of diagnosing vascular disease in children, including sickle cell, Moyamoya disease, and very exciting new gene defect called ACT2. I'm going to talk a little bit about stroke mimics, and I'm not going to talk about neonatal stroke or intracranial hemorrhage, because really time doesn't allow it. Childhood stroke is an important pediatric problem, and it affects about 5 in every 100,000 children a year. That means it affects up to 1,000 children a year in the UK. It is as common as pediatric brain tumour, which I think comes as a surprise to a lot of people. And it's one of the top 10 causes of childhood death. And against popular belief, 2/3 of survivors have residual morbidity. The Royal College of Physicians and IPSS is the International Paediatric Stroke Survey, recommendations for the imaging of childhood stroke is that we should do MR or CT as soon as possible, within 24 hours. And this is very important with 24 hours. The situation is slightly different to adults because, of course, we don't thrombolyze children, or very, very few children are thrombolized because there's no evidence base that children benefit from thrombolysis. We must image the entire vasculature, both intracranial and extracranial, and that's based on the fact that I'll show you that 80% of children who have childhood stroke have some form of vascular disease. And that the brain imaging should be performed much more urgently if children have depressed conscious level or clinically deteriorating. And in sickle cell disease, which is perhaps more of a problem in London, that new neurological symptoms or signs should be evaluated as potentially being due to stroke. And that having established the diagnosis of arterial ischemic stroke, that follow-up imaging should be performed at sometime between 3 and 6, and then 6 to 12 months. Now, the IPSS diagnostic definition of arterial ischemic stroke, or AIS as we now call it, is the acute onset of a neurological deficit and an imaging abnormality, a parenchymal infarct, which conforms to the arterial territory demonstrated by the neurological deficit. And this is a new departure where a clinical definition is determined by an imaging appearance. And a normal CT scan within 24 hours does not rule out an arterial ischemic stroke. And that's different from a transient ischemic attack, where the deficit resolves within 24 hours. There's no infarct on imaging, which corresponds to the clinical manifestation. So as I alluded to early on, between 80%, probably even more, children with childhood stroke have some form of vascular disease. And the most common is the focal cerebral arteriopathy of childhood, a different mouthful, so we call it FCA, or what has previously been called a transient cerebral arteriopathy, which is also a mouthful, so we call it TCA. And in the old days, when we had a focal narrowing that went away within 3 or 6 months, it was called TCA. And obviously that's not a diagnosis that you can make at the point of the infarct because you don't know what's going to happen to it in 3 or 6 months. So they've changed the definition and now call it focal cerebral arteriopathy of childhood, which is a diagnosis that you make at the point of the infarct, which can become a transient cerebral arteriopathy 6 months later if it's gone. So it's a little bit confusing. Other important causes are Moyamoya disease, which might be primary, so there's no underlying cause, and that's very typical of the Japanese cohort and a large population in our cohort as well. Or there are the secondary causes, NF1 radiation, you see it in Down syndrome, Williams, and arterial dissection is a very, very important cause, particularly in patients who have posterior circulation strokes, and I'll talk to you about that. Much less frequent diagnosis is vasculitis, sickle cell disease, associated arteriopathy, and post-varicella vasculitis. A large percentage of children will also have another factor, for example, factor 5 Leiden deficiency, or some form of coagulopathy which is additive to their vascular abnormality. And of course, cardiac causes are very important as well. And it will depend on the cohort. Great Ormond Street Hospital, we obviously see a large number of infarcts in children with cardiac disease because a lot of children there have congenital heart disease. So the role of imaging is to confirm the diagnosis, either arterial or venous, to exclude other diagnoses that mimic arterial ischemic stroke. And I'll talk a little bit about those at the end. Establish the underlying cause, that's why it's important to image the vascular tree, and it's very clear that the Royal College of Physicians guidelines really haven't reached the radiologists, because very often we see children who have had MRs but haven't had their entire vascular tree imaged. They may have the intracranial but not the extracranial portion imaged, and we will then go on to complete the investigation. We use imaging to guide treatment and monitor the progress of the patient. So this is a child that was sent with a right-sided hemiparesis, and you can see, well, this scan was reported as normal and sent in as normal. So the child went on to have an MR. You can see very obviously on the MR copy that the head of the caudate and the dutamen is infarcted, which is restricted diffusion on the ABC map. And in retrospect, and certainly a lot of radiologists would be able to see that there's low density in the head of the caudate. This is a very important sign, particularly in children. If you look at the head of the caudate here, you can see that it's dark, and you look at the head of the caudate there, and it's brighter. And then if you compare the putamen, it's clearly abnormal. And that corresponded with the side of the hemiparesis, and the child was diagnosed as having a stroke. I just also want to point out the importance of ABC maps. We use and Rolf will talk after the break about the role of diffusion-weighted imaging. I'm sure we'll cover stroke. In children, it seems that the restricted diffusion we see in the early stages of stroke pseudo-normalizes earlier in adults, so around 5 to 7 days instead of the 10 to 12 that's reported in adults. And then we'll go on to the pseudo-normalized and then diffusion. So we image these children using a standard brain protocol, and our standard brain protocol is just T1 weighted imaging in 2 planes and T2 weighted imaging in 2 planes. And it doesn't really matter if you use FLAIR or T2 or which one you use, whether you like axial FLAIR or coronal FLAIR, it doesn't really matter. But that's our standard brain. We then add the diffusion weighted imaging, axial T2 star imaging to detect hemorrhage, intra and extracranial flight MRA, a dual echo stir T1 weighted image through the neck, an MRV if we're considering a venous origin of the infarct, and we have yet to establish a role of susceptibility weighted imaging, diffusion tensor imaging, or diffusion imaging in the clinical arena. Obviously, these are imaging techniques that we use in the research arena, but they're not techniques that we can use in the clinical arena. So I'm sure you're aware of the utility of diffusion-weighted imaging in the detection of acute arterial ischemic stroke. And here's a case where the T2 weighted imaging doesn't really show very clearly where the infarct is, but you can see the area of restricted diffusion. And if you look back, you can see that the lentiform nucleus here is a little bit higher than it is on the right higher signal, which conforms to this area of restricted diffusion. And this was a middle cerebral artery infarct. But it demonstrates the value of diffusion-weighted imaging in the acute period. And I just finished talking about diffusion-weighted imaging to say that later on we see free diffusion, so these areas of gliosis that you can see here demonstrate high signal on diffusion weighted, on the ADC map. We tend to describe infarcts as hemorrhagic or non-hemorrhagic or anterior circulation, posterior circulation, and they tend to fit into two patterns, one of focal infarction and one of the diffuse pattern of infarction. And the vascular diagnoses range from just a prothrombotic state to this FCA, TCA diagnosis, which I'll talk to you about, varicella zoster, dissection, embolic disease, which can have just a single infarct or phases, and the diffuse pattern where embolic disease should probably be down here, but where you have diffuse vasculopathy, cerebral vasculitis, sickle cell disease, Moyamoya, reversible cerebral vasoconstriction syndrome, and I'm going to talk a little bit about, and then active 2. So, as I've said, FCA is a stenosis or occlusion of a distal ICA1N1 or P1, and the TCA is exactly that, but it resolves within 3 months or doesn't progress for 6 months. And a lot of these FCAs and TCAs have a history of chickenpox in the preceding 12 months of stroke, and it's thought to be about 50%. And these children are thought to have a post-varicella arteriopathy. And there are other causes as well, because infectious arteriopathy that have been described, but they're much less common. So this is an example of an FCA. This is a child who presented with a left hemiparesis, and you can see the area of infarction again in the head of the caudate and the lenticular nucleus. This is a very typical pattern of infarction that we see in childhood, and like the complete MCA tertiary infarct that you might see in adults. And that's because the area of narrowing is often, as you can see on this post-contrast CT, you can see this area of narrowing in the M1 segment of the middle cerebral artery. The lenticular striate vessels arise from exactly that segment, which supply the basal ganglia. If the thrombus is there, then it may be an incomplete occlusion, or there may be collateral supply from the posterior circulation, which is contributing to the perfusion of that hemisphere. But this is a very typical pattern from this sort of arteriopathy. And you can see that this child went on and, as required, had the MR, which confirmed the infarct, and an MR angiogram, which demonstrates that the arteriopathy is a bit more extensive, involves the terminal internal carotid at the M1 and the A1 segment on the right. We've looked at a series of children and published some data on arterial ischemic stroke and varicella zoster virus, and as I've just demonstrated, they often have unilateral infarcts, and they're most commonly basal ganglia, although they can extend to the subcortical white matter of the cortex. And the middle cerebral artery is almost always affected. It's usually unilateral. M1, ACA and TICA may also be involved, but we've not demonstrated any posterior circulation involvement. And as I said, with other vasculopathies, arterial ischemic risk factors may coexist. In our cohort, the vasculitis improved in over a half and completely normalized in 10%, progressed in 12%, and another study in a third in our cohort. And a third are stable. And the majority of these children had a good outcome. There are other manifestations of varicella zoster vasculitis, and this is a child with HIV who had a peripheral optic retinal necrosis and this dilated terminal internal carotid going into the anterior and proximal middle cerebral artery. And you can see that the right middle, this chronic infarction of the right middle cerebral artery territory. And then if you look at the vessel here, well, you can appreciate it. What I'm trying to demonstrate in the post-contrast is this enhancement that you see in the vascular wall. Actually doesn't demonstrate very well, but there's a lot of interest at the moment about the diagnosis of vasculitis in children using enhancement of the vascular wall, because, as I'll show you, the diagnosis of vasculitis is quite a difficult diagnosis in children to make. Arterial dissection is very, very important in children. It's a common cause of stroke in young, and it's very important, particularly if you have a posterior circulation infarct, to exclude a vertebral artery dissection. And the trauma may be relatively minor, or it may have occurred sometime preceding the cerebral infarction. And it can be associated with connective tissue disease, so we've seen it in children with Ehlers-Danlos syndrome. And the greatest benefit is thought to be from therapy in the first few days, but that's not very evidence-based, it's rather anecdotal. But we try and make the diagnosis early so that we can treat. The diagnosis of dissection is dependent on the visualization of the double lumen, that's, or the intimal flap or pseudoaneurysm, or the crescent sign as it's called, or a segmental stenosis or occlusion in the neck with a history of head trauma or neck pain in the 6 weeks preceding. And the other diagnostic criteria is a segmental stenosis or occlusion of a vertebral artery at the level of the C2 loop. The important message takeaway is that carotid tapering, narrowing stenosis without an appropriate clinical history is not diagnostic of dissection. So here's a child who's presented with a left-sided hemiparesis, got a right middle cerebral artery territory infarct, and you can see on the MR angiogram that the internal carotid artery, this is the internal carotid artery here, on the right is occluded, as is the A1 segment and the complete occlusion of the right middle cerebral artery. And a very nice actual T2 weighted imaging of the skull base shows the crescent sign. This is the diagnostic feature of dissection. And it can be seen not only on the T2 weighted imaging, but we can see it from axial stir images very nicely in this child who had a left vertebral artery dissection, and also in the base imaging, raw data of the MR angiogram of the neck. So it's important to look at all of the axial images to look for that sign. This child had a posterior circulation infarct. The thalamus is, for the most part, supplied by the posterior circulation, and had some slight reduced visualization of his left posterior cerebral artery, a small left vertebral artery, and a crescent sign. So this was a child with a left vertebral artery dissection. Now this is a child with a probable or possible left vertebral artery dissection who had multiple infarcts in posterior circulation. You can see the cerebellar infarct, one in the posterior temporal lobe, the splenial lesions, acute lesions, and areas of free and restricted diffusion, suggesting that perhaps they had occurred over a period of time, and a rather irregular looking vascular artery here that made us very suspicious that that was embolic, either in situ thrombus or embolic material from the vertebral artery dissection. The overlap between the intra and the extracranial vasculature wasn't at that time very good, so we missed the crucial areas, and you can see that you really couldn't really fault these terribly much, but you could just say that you can't visualize them well. And when the child went on to have cerebral angiography, not only did he have a left-sided dissection, they had this changing caliber of the C2 loop here on the left, but also on the right as well. Bilateral vertebral artery dissection. This is something that we see not infrequently in children with dissection. Arterial ischemic stroke is seen in this rather rare condition called Facey syndrome, which is children with facial hemangiomas, posterior fossa abnormalities, arterial cardiac, and eye abnormalities, and some associated with sternal defects. It was first described in 1978. And we have a cohort of children with great history with exactly this syndrome. There's a paper in Stroke last month that was written up describing a cohort of 20 children found in the literature. So it's an incredibly rare disease, but it's quite interesting. You can see this rather mature right middle cerebral artery stroke and a complete absence of right internal carotid artery that is developmental, and as a result of that, the child has developed numerous collaterals to get round the problem of this absent right internal carotid artery, and will be perfusing the right hemisphere through the left internal carotid artery. Facial hemangioma is not always very obvious, and this child's facial hemangioma was regressing during childhood and was underneath the hairline. But it's a nice diagnosis to make. And of course it had impacts, the diagnosis impacts on the management, because it's important and eyes in these children. So that's really covers the focal patterns of infarction. Diffuse pattern is usually seen in children, as I said, with diffuse vasculitis. And this is cerebral vasculitis in a highly contentious area at the moment. There's a group in Canada that seem to diagnose it in all of their children, and we never diagnose it at Great Ormond Street Hospital, and we don't know whether we're missing it or they're over-diagnosing it. But we haven't yet resolved that. But what we do know is that primary cerebral vasculitis in our hands is exceptionally rare. It's very difficult to diagnose, which might be why it's rare. We're looking at endothelial markers to see whether we can see other markers of vasculitis. Cerebral angiography can be negative in the majority of cases, and even biopsy is negative in up to 30% of cases. This is a 10-year-old boy who had bilateral lymphadenopathy for over a year. Then he had uveitis and he presented with TIAs, and he has multiple basal ganglia infarcts, head of the caudate here and the thalamus on here and posterior putamen. And they were all mature infarcts by the time he presented. He had a cerebral angiogram, and it's always very challenging to demonstrate self-abnormalities on cerebral angiogram. But what you're looking for is a change in caliber in the vessel. So you can see here it's very small anterior cerebral arteries and narrow middle cerebral here, and normal in an angiogram. So this child, the importance of diagnosing the vasculitis is that these children are treated with quite heavy-duty immunosuppressive therapy. As if you just have a focal arterioscopy, as we call it, that we don't think is active, then they're just treated with aspirin. So moving on to sickle cell disease, which stroke affects 5 to 8% of children with sickle cell disease, and by 10 years of age, 45% have cerebral infarction and 55% have vascular disease. So it's a very, very important disease in these children. And the infarcts can either be caudally based due to large vessel disease, or they have small white matter lesions in a watershed distribution, or they have periventricular lesions. We're not entirely sure what causes those, but the supposition is that it's like small vessel disease, sludging in vessels, and that's what causes that distribution of infarct. So this is a very, very typical watershed infarction in sickle cell disease, the watershed between the anterior and the middle, and the watershed between the middle and the posterior at the back. And this is clearly a chronic infarct. And you can see this just shows you exactly where the watershed is between the red middle cerebral and the green anterior cerebral circulation. And as I mentioned, there are a portion of children who have silent infarcts, these periventricular infarcts, and the risk of silent infarction in sickle cell disease is up to 25%. And there is some data that suggests that they have reduced cognitive impairment compared to the children who don't. So it's a very important thing to try and prevent in these children. Moyamoya disease or syndrome-fused disease, if there's no underlying abnormality, and the syndrome, there is an underlying abnormality, like NS1. This is a radiological angiographic definition. It's an inclusive vasculopathy with collaterals. The collaterals are Moyamoya collaterals, and I'll show you they are described in the Japanese literature as a puff of smoke. And clinical pointers are hemorrhages in young adults, ischemic stroke in children with a progressive cognitive and neurological deterioration, and sometimes a movement disorder as a result of basal ganglia involvement. And it's important to identify these children because they are candidates for vascularization. We're just about to publish a study or a cohort of children who are being revascularized at Great Ormond Street Hospital. And it seems that the perioperative risk of stroke is very small, and the children actually do very well with reduced risk of subsequent stroke after revascularization. So this is an example of a child. She actually had Down syndrome with a right hemiparesis, not previously diagnosed. They do often come with quite severe disease. You can see this. So this is a diffusion weighted imaging showing high signal in the ABC map, which shows restricted diffusions in the area of the left middle cerebral artery territory. And the MR angiogram shows this bilateral terminal internal carotid artery disease with flow, distal flow in the anterior and the cerebral artery, but some collateral vessels which you can't very well visualize on MR angiography, but it's seen very nicely on cerebral angiography. And these are the Moyamoya collaterals that the condition its name, sort of what I've described as class. So you can see the terminal internal carotid and these collaterals. A relatively new diagnosis for us is something called reversible cerebral restriction syndrome, which is a condition which seems to be well recognized in adults, but not terribly well recognized in children. This child is actually an older child, a 13-year-old boy, who went for a swim in some very cold water in Scotland and came out with the most severe headache as if he'd had a subarachnoid hemorrhage. And he had this imaging with these multifocal lesions in his white matter. And he had a whole slew of investigations to try and establish what the cause was, and we were completely perplexed. The only thing that we detected early on was that his right vertebral artery was small, and we wondered whether we could ascribe all those infarcts to posterior circulation, or was it vertebral artery dissection, because headache can be a feature. He had a, we were not particularly impressed by his MR angiogram, although we did wonder if his proximal A1 and M1 segments were a little bit abnormal. And again, very difficult to demonstrate here, but there is some subtle narrowing. And I think, particularly if you look at this image, there's sort of almost a beading here of his M1, terminal internal carotid. And then he's got this, well, this should not be confused with focal cortical dysplasia. This is a standing wave that you see when you put a catheter into an lenticular internal carotid artery. You ought to know more about this. But we don't see it very commonly in children. We wondered whether this was another sign that this child had very sensitive intracranial vasculature. His vertebral artery on the right was small, which is why we didn't see it, but it certainly wasn't dissected. And so we made the diagnosis in this child of RCBS, we call it. And subsequently, in another older child, we made a diagnosis. But it's something that is seen much more commonly in the adult population. This is a favourite subject of mine. At the moment, this is active two abnormalities, a particular vascular disease which is very characteristic of the gene defect, and we had very exciting news this weekend that this work is going to be published in Brain. And what we've done is collected 12 children who have this very distinctive cerebrovascular disease and an ACT2 gene confirmed in them. And this gene is associated with smooth muscle dysfunction in multiple organs. And these children often have a history of PDA in childhood. All our children have dilated non-reactive pupils, which is, of course, a diagnostic clue, and a characteristic cerebrovascular disease, which I'll show you. And it's seen in association with aneurysms, hypertonic bladder, obstructive lung disease, and GI disorders. And unfortunately, it carries a rather poor prognosis. So the children, a lot of the children subsequently have died. Some of them are still alive. So as I say, we've got 12 cases where we've seen imaging. And they can have anything from a normal appearing brain. So this is obviously a neonatal brain, picked up very early in childhood. And so before the infarction, you see this pattern of what you would describe in an adult as leukoariosis, or small vessel disease, which is something that we really rarely see in childhood, or a portal infarction. And these children have this characteristic tapering of the internal carotid artery here. So it's actually dilated more proximally, and then it tapers. And then you have very these very attenuated and straight vessels. And more peripherally, again, very difficult to demonstrate, but they have rather tortuous, very, very small vessels. As you can see that this child hasn't got any infarction, has got a relatively benign course. We've got follow-up imaging 1 and 2 where we haven't seen any progression of the disease, but we don't know how long it progresses over or whether in fact it progresses. This is a child child who sadly died. The diagnosis was made retrospectively, and you can see that there's a dilatation of the common carotid artery and then the internal carotid artery as well in association with an aortic aneurysm. And this originally, or in the original Act 2 papers, the cerebrovascular disease is described as a Moyamoya pattern. Well, it's clearly not a Moyamoya pattern. You can see that there's quite obvious distinctions between the two, largely that there are no Moyamoya collaterals. And this very, very distinctive straight tapering of the internal carotid artery. Posterior circulation is involved in some children, but not as severely. This is a child with a diffuse intrinsic pontine glioma with the centre of the brain stem off. He had some long tract signs. And the important thing here is that, well, there are a number of important things. One is the vascular artery is encased by tumour here, which of course you wouldn't see in an infant. You get swelling of the pons in vascular artery occlusion, but you certainly wouldn't get that encasement, so that's an important sign. And also the other important sign is that it's free diffusion, and if this child presented acutely as he had, you would expect that to be restricted. So there are two features from that really say to us, this is not pontine glioma. The third is that the child just has some long tract signs, and if you infarct your pons, you don't do very well at all. And if you've just got a little bit of long tract signs, then it's likely that it's going to be tumour, which is in fact what it was. The posterior reverse polyphony encephalopathy syndrome, which is something we see in children who are treated with things like cyclophosphamide, or patients who have intractable hypertension or a combination of them. And this child had a CT scan and was thought to have a left posterior parietal infarct. When he went to have his MR, you can see that he has this free diffusion on his ABC map and areas of brain swelling, particularly in the posterior distribution. That's not. It's important that that you don't take away the message that all of these abnormalities in the posterior circulation, you can see them anteriorly. They are reversible, and they don't always affect the white matter. So it's a very, very good name for this disease. The other acronyms you may have come across is correct. This is another case which being started third World War in hydrocarbon. Right coming paresis whilst in a swimming pool, and died clinically. The child was diagnosed as having a stroke. Radiologically, he had this basic ganglia lesion which has got a bit of fluffy margins, which also on the ADC map has as an area of free diffusion as well as restricted diffusion, which would be odd for a single stroke. And the vasculature, both on MR angiography, and we went on to do CT angiography, was in fact normal. And this child was diagnosed as having a clinically isolated syndrome. His neurology resolved within 24 hours and went home and remains well. Of course, there are other causes of strokes, other genetic defects, mitochondrial disorder. This is a particular point mutation that's been identified in this child. You can see the gross cortical infarction and the very typical bilateral symmetrical basal ganglia calcification that makes you think of mitochondrial disorder. So in summary, brain imaging is important to confirm whether there's an infarct or hemorrhage, or whether you're dealing with a stroke image. You know, an MR, of course, is better than CT. Diffusion-weighted imaging is important for the identification of subtle infarcts and infarcts of different ages. As yet, there's really no clinical role for susceptibility-weighted imaging or TTI. It's very important to image the intra- and extracranial vasculature to establish the vascular cause, always in dissection, machine trauma. CTA can be used for arterial ischemic stroke if MRA is not available, and MRB is useful for venous infarct is suspected. There is a role perhaps for infusion imaging. We only use it in Moyamoya to look at revascularization, to look at diffusion following revascularization. in communication cancer. And we reserve several angiographies for cases with complex vascular disease or equivocal vascular disease. There's a list of some stroke members, some of which I've demonstrated examples of, and really there's the old adage that imaging, when you're imaging children, they're not simply young adults. You must think about the disease in that group. Thank you very much.